Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest tonight is Dr. Emily Merfeld. Welcome, Emily.
Thank you very much.
So Dr. Merfeld is one of my colleagues and partners at Mercy Cancer Center, radiation oncologist. So welcome. We're going to be talking a bit about a lot of things tonight, obviously radiation oncology, but we're also going to talk about the role of women in medicine, and I would say marriage and families and trying to juggle it all with profession and family.
Sounds good.
Okay.
That sounds great.
Let's get to know you first. Where are you from
All right.
originally?
I'm from right here in Des Moines.
Right here in Des Moines.
Yeah.
Where did you go to high school?
I went to Dowling.
Okay. A big, prominent high school. What was your claim to fame in high school?
Well, I did cross country and played tennis in high school.
Okay.
But I was fairly academically driven, I would say.
Gotcha.
So that was
academics and sports.
Yeah.
And did you realize in high school years that science was kind of your thing and that you wanted to go into medicine? Was that something that you realized early on?
Yeah, pretty early on, I would say. Definitely during high school, I really enjoyed my science classes. And I had some family members who were physicians. My mother is a nurse. So I kind of had that familiarity there and liked the idea of combining the science with working with people and hopefully helping people. So yeah, I think it was sometime during high school that I decided I wanted to be a physician.
Okay. And then where did you go to college?
I went to the University of Iowa.
Okay. And what was your very first declared major?
I actually started with a major in math because I just really loved math. And I thought, well, I can still go to medical school, but do a major that I really love. And so I majored in that for a while, but then math got really abstract and kind of weird and such that I stopped enjoying it. So then I switched to biology, which is what I ultimately graduated with.
Okay. And then where did you go to medical school?
I went to Washington University in St. Louis.
Okay. And how did you choose WashU?
I was planning to go to the University of Iowa. And then when I got into WashU, really good school. And I liked the idea of kind of going away from Iowa in the back of my mind, thinking I'd probably try and come back someday, but I liked the idea of kind of going away for a bit.
And WashU is a Jesuit school? Is that right?
No, it's private.
It's
but
private. Okay.
Non-religious.
Okay. What's the Jesuit school in St. Louis?
St. Louis University.
Okay.
Yeah.
I don't know St. Louis very well. I did know there was a Jesuit school there. So Washington, it's St. Louis University, which doesn't have a medical school, right?
They do too, actually.
They do? Okay.
Yeah.
How many medical schools in St. Louis?
I think just those two.
Okay.
Yeah, but they were about a mile apart. So close.
How was living in St. Louis and medical education in St. Louis? Was it kind of the traditional medical school where the first 2 years were classroom and the second 2 years were clinical?
Yes, it was the traditional curriculum, although since I've been there, I know they've changed that up a little bit, as many medical schools have. But it was really good. I really enjoyed my time there. I had really great classmates and friends. So we got through it together. And then clinical rotations there were really great, definitely an at-risk patient population in St. Louis, which was really good. Good for learning and just really opened my eyes, and all in all, a good experience.
And did you do quite a bit of oncology as part of, and did you early on in your third and fourth year realize that oncology in general or radiation oncology specifically was what you were interested in?
Yes. I knew from fairly early on in my clinical rotations that I wanted to do oncology of some sort. It was during my gynecologic oncology surgery rotation that I just really was drawn to the patients with cancer and talking through, difficult decisions about treatments, benefits, risks, and kind of overall what were the patient's goals and things like that. So I then, for a while, had planned to go into GYN oncology and then sort of backtrack to not wanting to, not realizing I didn't like the operating room quite that much. So then I thought about medical oncology or radiation oncology. But my aunt is a radiation oncologist, and she really encouraged me to give it a try. So I did. And then I just loved that. And so then that was kind of an obvious choice for me.
Did you get the opportunity to do radiation oncology rotations in medical school?
Yes, I did.
Okay. Okay. So then medical school, WashU in St. Louis, and then your residency was?
I then went to the University of Wisconsin in Madison for residency.
And that's another great college town.
Yep.
And so how many years of training total after medical school?
Then 5 years.
5 years, yes. What was your experience like at the University of Wisconsin?
It was great. Again, I worked with really amazing people, and saw a lot of, challenging clinical situations, and worked with multidisciplinary teams. And I think just provided a really high level of cancer care, which was a great environment to learn in.
So that's the Paul Carbone Cancer Center.
Yes.
And one of the NCI designated comprehensive cancer centers. Did you, was it a requirement to also be involved in research during your training?
It was, yes. We had some time during our training that was dedicated to research time. So it was expected that we did that, and I mostly did clinical research, patient outcomes and experiences among patients at the University of Wisconsin. But I worked with some people at different institutions as well throughout my time to do kind of some multi-institutional work.
And we talked about how, and we agreed to this before we started the program, to talk a little bit about the personal side of life and how life and medicine mix. So I would gather that sometime in your time in Madison, you developed a relationship.
Yes.
I don't know if that happened in...
I met my husband on the first day of intern year.
Okay, in Madison.
Yes.
Okay.
Yep. So in radiation oncology, we do 1 year of internal medicine, as you know, before radiation oncology, and he was an internal medicine resident. So that's how we met.
So we're going to have him as guest next year because he formally finishes his pulmonary medicine critical care fellowship and is moving to Des Moines in about a month.
That's right.
And so you guys met during that first year. Where did he grow up?
He grew up in Houston, Texas.
Oh, okay. And so then during the course of your residency, you're not only becoming a radiation oncologist, but somewhere in there, you probably got married.
Yeah, that's right.
And where were you in your training at that point?
That was during my 4th year of residency.
Okay. Yeah. So I only imagine like all of the stuff going on as two training doctors with call schedules and, really demanding jobs are trying to figure out everything, including having a child.
Yes.
And refresh my memory, your first child, your daughter was born during your residency.
That's right. Yeah, during my last year of residency.
So how did you do it all?
We were really lucky. We were able to stagger our schedules, and our programs both worked with us a lot to do that. So I had some time off right after she was born, and then he had some time off after that when I went back to work. And then my training program was very front loaded. So a lot of my call I purposely scheduled it this way. In part, I got a lot of my call done before she was born to kind of ease the load afterwards.
And so your last year of residency is really, although you're learning a lot, you don't have to take as much call. You had a little bit more flexibility in your schedule, some more elective time.
Yes.
And maybe research time. Okay. And then what is it like for your first job out of training to come back to your hometown?
It's been great. It's been really, really wonderful. First of all, just to be back with family and friends, and my family has been very supportive. But second of all, it's fun to get to know patients and kind of make connections about where they're from or where they live, and just kind of myself refamiliarizing myself with Des Moines after being gone for 15 years or so. So it's been really special to be back where I grew up, and kind of help patients here in Des Moines and surrounding areas.
So your husband's originally from Texas,
Mhm.
came to the upper Midwest. Where did he go to undergrad?
He went to the University of Houston.
Okay.
Mhm.
So then medical school for him was?
University of Texas.
Oh, right. So
Yep.
Madison was his first time to
Yeah,
the upper
that's
Midwest.
right. That's right.
Okay.
Yes.
And obviously he took to it, or at least he took to you.
Yes.
And so he's going to become an Iowan.
Yeah, that's right. He's looking
Okay.
forward to it.
Well, very good. And for those of you who can't see, Emily is going to have her second child here this summer.
Mhm. Yes. Yeah.
So maybe talk a little bit about, your own expectations of yourself as a physician, wife, and mother. How do you prioritize all
Mhm.
of that? And I just admire you. You inspire me. I can hardly keep track of myself, let alone trying to imagine what it would be like. So
Yeah.
maybe reflect a little bit on that.
Sure. It's I think none of those areas are I guess areas of your life that you can give less than 100% in being a mother, a physician for your patients, and a wife. And so you just have to do what you have to do, and do your very best for your patients, for your child and your husband. I definitely have had to lean on people around me, so my parents have done a lot of help with childcare this year, in addition to daycare. Um, and then, at work, I have excellent partners, and we all help each other out. Our nursing staff is incredible, and they help out a lot, and I trust them a great amount. And so, I don't know. You somehow at the end of the day, you just get it all done.
You do what you have to do, and it gets done.
Yes.
Yeah.
Yes.
Well, great. Well, thank you for sharing all of that, because I think people are interested in it, especially you're such a caring person. I can imagine that you have many patients that want to mother you in addition to being doctored by you.
Maybe, I don't know.
So let's switch gears and talk about radiation oncology, something I know a little bit about as well. But
Yes.
so you described a little bit about your path toward radiation oncology, and maybe tell us a bit more about why you see radiation oncology as such a special field that is attractive to you as a physician.
Yeah, I mean, I think radiation oncology is, in terms of our contribution to overall cancer care, I think it's immense. And I think it's really neat how radiation oncology has a role in both the curative setting. So for many patients, radiation is the primary curative modality in their cancer care. And then for other patients, it's in more of a palliative setting, and can help people a great deal in that way as well. So I think it's a really great treatment option for patients, across the spectrum of cancer care. And then as a physician, I think it's really interesting. Biologically, all the interactions with the various systemic therapies, which the advancements in that realm are just incredible, even over the last couple of years, and dating back further than that. But then I think as radiation oncologists, personally, I think it's amazing to get to review anatomy and scans and just kind of see how the human body fits together that way. So I think we have kind of a combination of a lot of really interesting parts of medicine and parts of humanity and patient care.
Right. So from a science point of view, obviously there's the anatomy, the physiology, the interdisciplinary, and then you also touched on. I mean, one of the things that I like so much about it is, as radiation oncologists, we get to know our patients better than many specialties because, for those who might not know, it might be it's not. It's very common for a patient undergoing radiation treatment to get a treatment once a day, Monday through Friday for weeks. And so in the process of getting to know the patient, you have many, many interactions over the course of a week that is very conducive to actually getting to know the patient as a person, what they're like, and they get to know you, and that bond that develops as part of this relationship.
Yes.
And on top of that, from the very beginning, you say the word cancer and, mortality and meaning and purpose and everything is kind of in the room at work at once, which is so conducive to those relationships that become, for the patient, very therapeutic.
Yes, definitely. Yeah, I was really drawn to that in radiation oncology, that we do get to develop those close relationships with our patients during the course of treatment and then, beyond as well. So, and obviously when patients are going through such a difficult time, sometimes they enjoy the distraction of just chatting about non-cancer related things, and other times they are kind of having some of those deeper internal struggles, and the conversation goes there. So yeah, we're in a unique position in that way.
So back when I did my training in radiation oncology at University of California, San Francisco in the 80s, it was not very common for radiation oncologists to subspecialize. So pretty much everybody did everything. And really radiation oncology was still pretty new back then. For those who don't know, radiation oncology actually came from diagnostic radiology, and the first radiation oncologists were just kind of learn on the job that because we're dealing with radiation, the field of diagnostic radiology, is over 100 years old, and the first folks who used radiation to treat cancer as opposed to just diagnose cancer were diagnostic radiologists. And then we're still certified by the American Board of Radiology. So the first step was having a different training program for those who did radiation oncology. And back in the beginning, we called it radiation therapy. So diagnostic radiology and radiation therapy. And the number of years of training has gone from 0 up to 5, and also has become in larger groups where there's a bit of subspecialization. And that prelude is up to asking you, do you have particular types of radiation oncology or diseases, cancers, that you are kind of are favorites or that you have more interest in?
Yeah. I like GYN oncology, gynecologic cancers, which is something I mentioned earlier. I had taken an interest in medical school, and then my training at the University of Wisconsin was really strong in GYN and specifically in brachytherapy, which is using radiation internally, procedurally to treat cancers, commonly for gynecologic cancers. So I really enjoy that. And I think since I've been here at MercyOne, I've been treating a lot of breast cancer, which I really enjoy as well. And I think beyond that, I love the variety. So I think treating everything is keeps things interesting and is enjoyable for me.
At the University of Wisconsin, in your training program, did the faculty tend to subspecialize?
They did, yes. So there, and I think at most academic centers nowadays, faculty tend to subspecialize in GYN or breast or CNS or thoracic oncology, those sorts of things.
Mhm. Yeah, I've never been in a group that's subspecialized, so I kind of like you. I like it all, and
Mhm.
if you told me I had to have one, I would probably think of it philosophically as you're denying me all those others that I like. So I
Yes.
probably would view it not as an opportunity, but that I would be denied the the breadth and depth of all the different types of cancers,
Mhm. Mhm.
especially if were relegated to just a woman's cancer or just a man's cancer.
Mhm.
I think I like the opportunity to see more individuals. At our cancer center, we don't have pediatric oncology.
Mhm.
So, pediatric oncology is a smaller subset. At the University of Wisconsin, I imagine you did have pediatric
Mhm.
oncology
Mhm.
and did some work as a radiation oncologist in the pediatric world.
Yes. Yes.
And what was that like?
That was hard. I don't think it's something that I would want to or could specialize in. I thought it was very very challenging to deal with, or not deal with, but be with families and children as they're going through that kind of a devastating diagnosis and treatment, and just the long-term implications that
Hmm.
the treatments can have. Although that being said, the cure rates for most pediatric cancers are much higher than kind of the average adult cancer. So that's obviously a positive. But it
And I
was
would also say, correct me if I'm wrong, that the radiation oncologists definitely take a back seat to the pediatric oncologists, and
yeah.
more,
Hmm.
there's the desire to try to eliminate as much as possible
Hmm.
using radiation in pediatric cancer. So the real
Yeah.
focus and the research and where we're going in pediatric is more with the
Hmm.
medical oncology side than the radiation side.
Yeah, definitely. And fortunately, radiation has kind of worked its way out of standard of care for many pediatric cancers. And in those that it hasn't, sometimes we've been able to lower indicated doses and things like that, to reduce some of those long term risks of the treatment. But I agree with that in pediatrics, it's more often the pediatric medical oncologist who's making a lot of those bigger decisions. And I think a lot of pediatric cancer care, kind of like here at Mercy, is happening at those academic centers, just because it's so subspecialized, and the vast majority of children are on national clinical trials and things like that, which is great for moving the needle forward, for those kids. But I think it's fairly common that a place, like Mercy, even though we serve a large city like Des Moines, doesn't, treat children.
Mhm. What would you say were some of the main differences of 5 years at the University of Wisconsin, a very large NCI designated comprehensive cancer center, and then coming to MercyOne Des Moines, a comprehensive community cancer center? What are some of the differences you see in the practice of oncology in general and radiation
Mhm.
oncology specifically?
Yeah, there haven't been as many differences as I thought there would be. To be honest, I think that the from in within radiation oncology, I think that the way that all of my partners practice is extremely similar, to the way that the physicians at the University of Wisconsin practiced. I think not a lot of differences, to be honest. And here at Mercy, we have all of the support staff, be it nutrition, speech and swallow therapy, nurse navigators, all of those things that we had at the University of Wisconsin. So in that way, the differences haven't been all that noticeable. And then in kind of cancer center more broadly, we have several disease site specific tumor boards here at Mercy, which is similar to how it was at Madison. Obviously, just everything on a little bit of a smaller scale. But I would say the similarities are more than the differences.
Yeah. One of the things that I've seen in my career, I graduated from medical school in 1980. And, there was a time where you had to go to the library to look stuff up and get articles. And one of the things that I think has made cancer care more universally similar across the country, back when I trained, there were huge regional differences between the way cancer might be treated at MD Anderson versus Memorial versus, UCSF. And with what we call the NCCN guidelines, which are available online and updated, instantaneously, that has become the guideline and the way things are done, and it's so readily accessible.
Definitely.
I can't remember the last time I actually went to a medical library to look something up, because everything is just instantly available.
Yeah.
So I think that computerization of information that makes it instantly readily accessible, and the development of these national guidelines that everyone uses has made cancer care more standardized.
Yes, I definitely agree. And a new study comes out, and it's all over the internet for physicians, whether they're at an academic center or whether they're at Mercy here in Des Moines or in a rural setting. Everyone has access to that information. So I think hopefully that does make things more standardized and gives kind of equal care to patients everywhere. So I think that's a really good thing.
Okay. Let's talk a bit about the principles of radiation therapy. So maybe start fundamentally. Why does ionizing what is radiation and how does it kill cancer cells?
So radiation.
Now that can be the course. That could be a whole academic career in and of itself. But.
Yes. So radiation therapy is done usually with photons, although sometimes we utilize electrons, and at some place they utilize protons. But all of those being ionizing forms of radiation, the radiation works by damaging DNA. And the reason that is effective in treating cancer is that cancer cells' DNA is already sort of distorted, and so just a little additional damage from the radiation can oftentimes push cancer cells over the edge and cause them to die. Whereas there is some damage and effect to normal tissues, as any patient who's or as many patients who have received radiation therapy know, but our healthy tissues are much more able to repair that damage and repair damage from the radiation, which is why radiation is a good tool for targeting cancer.
Yeah. And then the physics and imaging and sort of focusing of the beam. So I would say one of the things that has changed dramatically in my 40-some years is the ability to localize the cancer better with imaging and trying to be more focused and smaller fields, higher dose, and less collateral damage. And then obviously, maybe not obvious to everyone, but the world of medical oncology is just expanding from old-fashioned chemotherapy to chemotherapy, targeted therapy, hormone therapy, immunotherapy.
Mm-hmm.
We haven't really invented that many new ways of doing radiation. We've just
Yes.
gotten better at
Mm-hmm.
localizing and focusing.
Mm-hmm. Yeah, definitely. The imaging, it's incredible. The small size of metastases you can see with an MRI, or a PET scan, or those different things, which has allowed radiation to really move forward. And I think on the topic of all the new systemic treatments that we have, there's so much research being done into how does radiation interact with those systemic treatments, and how can radiation work to optimize outcomes for patients who are now living longer because some of those systemic treatments, and how can they kind of synergistically work together. So I think there's a lot of excitement happening there with radiation, even though we don't have the new new drugs and all of these kind of new developments on paper that medical oncology has.
So the three most common cancers in America and in Iowa, in terms of incidence, are breast cancer, prostate cancer, and lung cancer. So
Mm-hmm.
maybe just a little bit on those three, since those are the three most common. And let's talk about the use of radiation therapy in a localized breast cancer, a stage 1 or 2.
Mm-hmm.
So what's the role of radiation therapy in early breast cancer?
So the main role of radiation for early stage breast cancer is following if a woman has a lumpectomy for breast cancer, as opposed to a mastectomy where the whole breast is removed. Radiation is typically given following a lumpectomy to the remainder of the breast tissue to reduce the risk of recurrence in the breast.
And what's a typical course of radiation therapy after a lumpectomy for early stage breast cancer?
Usually about 3 to 4 weeks, 15 to 20 treatments every day, Monday through Friday.
And each treatment takes how long?
Usually less than 15 minutes or so. Sometimes the first day a little bit longer to get things, kind of extra safety checks that day, but fairly quickly.
Fairly quickly. And in reality, the amount of time that the radiation beam is turned on is probably closer to 1 to 2 minutes.
Yes.
And it takes 10 to 15 minutes just to kind of set the patient up, make sure they're in the right position, the beam is focused right, that the actual time that beam is turned on is very, very short.
Yes.
So that would be kind of a traditional role of radiation therapy in early stage breast cancer. How about prostate cancer, the most common cancer in men in terms of incidence? And let's talk about organ confined or prostate cancer in the early stages where it is just in the prostate gland. What's the role of radiation therapy in early stage prostate cancer?
So radiation can be used as the sole treatment modality to cure the cancer. So many patients get radiation to the prostate over the course of anywhere from 5 to 7, occasionally more like 8 weeks, to with a goal of curing the cancer.
And one of the newer ways of doing radiation is stereotactic radiation. Maybe explain what that is. And then I'm interested, I don't know that we've talked about this. Were you doing stereotactic radiation for prostate cancer at Wisconsin? And maybe talk a little bit about the role of stereotactic radiation for early stage prostate cancer at MercyOne.
Yeah, definitely. So, SBRT, stereotactic body radiation therapy, refers to giving a high dose of radiation per treatment with a smaller number of treatments, usually 5 or fewer treatments. And in order to safely do that, the treatment needs to be very precisely planned and precisely delivered to the area at risk, in this case, the prostate. So we were doing quite a bit of it at the University of Wisconsin. It's a treatment modality that's a little bit newer than standard radiation for prostate cancer, but there's good safety data and efficacy data for 10 plus years out after men finish treatment. So it's not brand new, or definitely not experimental by any means. But it's a really good treatment option for men. It's been shown overall to have similar side effect profiles to more standard radiation, and allows men to get done more quickly, which is which is great.
Right. If you're a farmer and it's spring,
Yeah.
getting 5 treatments instead of 40
Yes.
can be a huge benefit logistically.
Mhm. Yeah, so here at MercyOne, we're mostly doing that on the CyberKnife machine. Typically, men before getting the CyberKnife treatments do have to have some fiducials placed by a urologist. Those are just little, basically like surgical clips that they place into the prostate that allow us to track in real time during their radiation treatment. The location of the prostate, because they sit within the prostate, and then the CyberKnife machine is able to follow those and deliver very precise radiation.
Because the prostate can actually move during treatment as the bladder drip by drip fills with urine. And as stool or gas goes through the rectum, there can actually be movement of the prostate.
Yes. So that's a really exciting option to have for patients.
Okay. And then the third most common cancer, but the number one cause of death in terms of cancer, is lung cancer. So what is the role of radiation therapy in the curative treatment of lung cancer, and maybe talking about stages 1, 2, 3?
Yeah, so for earlier stages 1 and 2, where the cancer hasn't spread to lymph nodes, radiation, typically using SBRT, the stereotactic body radiation therapy, which here at MercyOne we do with the CyberKnife machine, can provide high cure rates comparable to surgery for early stage lung cancer, typically in 5 or fewer treatments. So really excellent option for many different types of patients, including patients with lung function that might not make them might not make surgery a safe option, or things like that. And then for a little bit more advanced lung cancer, radiation is commonly given in combination with chemotherapy with the goal of curing the cancer. And then that's typically more over the course of about 6 weeks or so of treatment every day.
So once a day, Monday through Friday, for about 6 weeks. Okay.
Yeah.
What are the main side effects of radiation therapy?
Yeah, so it depends where in the body we're treating. So radiation is it's a localized treatment modality, but I always tell anyone going through radiation that it can make you more tired, and then depending on the area of the body, in the breast, the main side effect can be discomfort or pain in the breast, and then skin reaction. So kind of like a sunburn, where the skin can get red and sometimes even peel or get more like a more serious sunburn. And then, to the abdomen and pelvis, it can cause sometimes nausea, diarrhea. When we treat the head and neck area or any area along the esophagus, it can irritate some of those mucosal surfaces and cause associated pain with that.
So unlike chemotherapy, which the side effects can be anywhere, radiation side effects really tend to be specific to where you're pointing the beam.
Yes, exactly.
Yeah. So obviously, if a person has brain tumor and you're treating the head, you're likely to see hair loss. But if you're treating the chest, unless it's a guy with a hairy chest, you're not going to have much hair loss.
Yep.
Yeah, but you will have hair loss in the area that you were treated. What about what we call late side effects? So most of what you mentioned in going through the side effects are the side effects that patients are likely to experience while they're going through radiation. And one of the reasons that many surgeons and other specialties aren't fond of some aspects of radiation is some of the late toxicity of the side effects that can happen years after radiation. Maybe talk a little bit about the difference between what we call acute toxicity, or side effects that happen while you're doing the radiation, and late toxicity, or side effects that happen years after the radiation.
Yeah, so again, late side effects tend to be specific to the area of the body that we're treating. So just to give A few specific examples in the breast can get radiation anywhere in the body can cause scar tissue. So the breast, there can be cosmetic changes to the breast. It may be more firm, more pigmented, the skin. In the lung, for example, radiation can additionally cause scar tissue within the lung tissue itself, which is for a lot of people is just something we'll see on future scans and doesn't functionally cause any limitations or changes in their breathing status. But for some patients, it can impact longer term respiratory function. In the abdomen and pelvis, radiation can lead to some long-term bowel and bladder changes. So some patients will have kind of chronically looser stools or increased urinary frequency or kind of urgency with urination. In the head and neck area, some of the longer-term side effects can be more significant and even life-changing for people in terms of dry mouth. Occasionally, if there's enough scar tissue, there can be trouble with swallow function and things like that. So very, very specific to the area of the body we're treating and the radiation dose and kind of all of the factors, unique to that specific patient.
Yeah. And with the recognition and that those late side effects can happen, and they're often related to how big of a field was treated and how high of a dose, and they happen years afterwards. So with many decades of seeing late toxicity that was pretty severe, one of the ways that we've modified radiation is to try to be more precise and even in some diseases lower the dose to avoid tissue that we know doesn't have much of a problem with the acute side effects, but with the delayed side effects can be great.
Yes.
Let's open it up for questions, because I know we've got a large studio audience here. And if you are watching us live streaming right now, we invite you to put your questions into the comments section. So anything's fair game. We're talking about for the profession of medicine. We're talking about juggling motherhood, marriage, and a dual profession in medicine. And we're talking about radiation therapy and cancer. So invite some questions. I think Angelina has Boone, you have the first question.
Yes. Just going back to the radiation for breast cancer patient, what do you see with lymph nodes being radiated? What type of long-term side effects?
Yeah, that's a great question. So radiation as well as surgery can result in lymphedema, where the lymph nodes just don't function as well, and women can have swelling in the arm, which can range from a mild annoyance to a more major functional limitation for women. And that's oftentimes dependent on the extent of the axillary lymph node dissection that she had, the number of lymph nodes that were removed, and then furthermore, whether the radiation targeted just the breast or did the radiation target the lymph node areas as well. But that is definitely a side effect that we think about, when we're talking about treatment decisions with patients. And unfortunately, there are therapies. We have wonderful occupational therapy team that works with women on exercises and sleeves and different kind of options to help minimize and manage those long-term effects.
That was actually a good question. But I wanted to elaborate more on the late effects. Like, I've been through that. I panicked and went to Dr. Deming. Hey, I think I feel a lump. And it was just like months after the lumpectomy and going through the radiation treatment and understanding about scar tissues. But how long, or is that just different for individuals? How long does that last usually?
Yeah, so scar tissue, oftentimes when scar tissue is present, it can be permanent and lifelong. There are things that people can do to, various stretches and exercises to help kind of break up that scar tissue or try and make the joints and range of motion more flexible. But to some, the scar tissue, can be permanent, and the kind of functional impact of that can be permanent as well.
I have recently had surgery and have already developed lymphedema. So my question is, and I'm scheduled to meet with you, by the way.
Good.
So how does that impact then the radiation potential treatment that I might be engaged in? You can see I'm already wearing a sleeve. Does that influence the methodology or the time frame? I was told I have to completely heal before the radiation starts. So it's sort of a 3-point question, but that's the first one.
Yeah. So great question. We definitely like for women to heal post-operatively. And, I've seen women who come in to see me 3 weeks after surgery, and they're having a lot of problems with either lymphedema or range of motion or cording in the axillary area. And then I say, well, let's wait to start the radiation, give you, some more time to recover. And then I see them 3 or 4 weeks later, and they've been working with occupational therapy, physical therapy, and they've made major strides. So that is definitely something we try and allow to happen before we start radiation, within reason and within certain time limits. And then how does it impact the radiation that we give? So there are some women who, based on the risk factors of their cancer, it's very much in their best interest to target not only the breast but also the lymph node areas that surround the breast. Other women, it may be a little bit more of a gray area. How beneficial is it going to be for you individually to target those lymph node areas? And if we think it's a little bit more borderline and you're having more lymphedema, then we might say, well, I think kind of in weighing risks and benefits, it might be best to treat just the breast for that patient. So definitely something that we think about in kind of deciding timing of radiation and then radiation field.
Did you have a follow-up question? You can do the follow-up question, and then Judy can go next. Is that okay?
I know that there is some burning that can be experienced in the process of radiation treatments. For African American women or melanin in the skin, is that a higher probability or a lower probability?
Maybe repeat the question.
I heard it.
Yeah.
I don't know if people
It
in the
wasn't
audience
recorded.
did, though. Oh, okay.
Yeah, for the videotape.
Oh, I'll repeat it. So she asked, there can be radiation burning of the skin, and she asked if African American women tend to experience more or less of that burning effect. And I would say it's actually about the same on average. So any individual patient, you never know exactly how their skin is going to react. But some African American women or women with more melanin in their skin can have, a worse skin reaction. Some can have less. It's just really variable.
Okay. Judy? We'll get the microphone turned on here.
It seems that the radiation research and, the different innovative things that are going on and leading to maybe not a cure, but at least making cancer not quite so threatening or not quite so tragic, I guess, maybe prolonging life and a lot of different things I know that are being done. And along with that, it must be very costly to fund all this. And with the cutbacks at federal and all levels of government, basically, it would seem like you would need more money going forward for these very costly research projects. Is that available at all levels?
For the research component, yeah, that's a really good question. And funding for research, I do think is for, in some fields becoming more challenging to come by. So, I think that's something that particularly people who have their own laboratory and that's much of their career focus on a lot. I haven't personally done as much seeking of funding, but I know that that's definitely on researchers' minds.
And I would say there's kind of two different buckets of research when I think of radiation research. So one is clinical trials research, where we might be looking at doing a different dose of radiation. Let's say we have a type of cancer where the cure rate is nearly 100%, and that we have a lot of side effects. If your cure rate's 100%, there's a great possibility you might be over treating every patient, and perhaps you could get the same cure rate with a lower dose and fewer side effects. So that sort of a clinical study can be done and isn't hugely expensive. Where I went to my residency, the University of California, San Francisco, we also had the Lawrence Berkeley Laboratory at Berkeley, where they were doing cyclotrons to come up with using nucleus from atoms to treat. Now that sort of research, where you're running a research facility, not unlike building a nuclear bomb, I mean, that sort of research requires probably billions of dollars to come up with some brand new type of radioactive particle, and then to figure out how to turn that machine into something that you can put a patient in front of. So just two different broad differences of research that happens in the world of radiation.
Yeah, and I haven't heard as much concern about funding with regards to the first type of research you described, the clinical trial type research, as opposed to the kind of more expensive second thing you described. So,
and at MercyOne, we have a grant with the National Cancer Institute. So we have 60 clinical trials that are open, and some of those do involve radiation and different ways of doing radiation. I would readily admit most of those are looking at newer drugs or different combinations of drugs, but that clinical research where you're using radiation equipment that you already have, that we know the safety and efficacy, and you might be just doing it with different doses, or doing it radiation by itself versus radiation and immunotherapy for early stage lung cancer, for example.
Mm-hmm.
Kevin?
Yes, as a patient, I appreciate the Monday through Friday, and then Saturday, Sunday off, and I'm sure the oncologist does too. But the cancer cell itself has no idea what day it is. So how long has the Monday through Friday been going on, and are you seeing any changes, like possibly? Did they do studies about that?
That's a good question. So, I think the doses that we use now have come to be standard of care in the setting of clinical trials that were done with 5 days per week. So, I think that's been the standard for decades. So I think for that reason, if we were to stop taking weekends off, we may need to lower the doses a little bit to make it, equally tolerable and with equal cure rates. So I think that's just how it's been done for a long time. There are specifically in head and neck cancer, occasionally we'll give treatments, like 6 treatments per week, because certain types of cancer, including head and neck cancers, are sensitive to how long the total treatment time is. So sometimes we'll do 6 treatments per week, where 1 day a week the patient gets 2 treatments. And so that's something that is being done to sort of escalate the timeline over which the patient finishes, or expedite, the timeline over which the patient finishes.
Yep.
Okay. My final question, both my medical oncologist and my surgical oncologist have tried to, in an effort to reduce my stress level, talked with me about the advances you mentioned earlier, Dr. Deming, about in radiation oncology relative to being able to localize and target. Has that had any impact on, piggybacking on your question, having to be there 5 days a week, or now that you can more closely pinpoint where you need to apply that radiation, does it mean that it's shorter weeks or fewer days or any impact at all?
Good question. So, yes. So, if, for example, when Dr. Deming asked me about how we treat stage 1 breast cancer, if we were having this conversation 10 years ago, I probably would have said that most women got 5 to 6 weeks of daily radiation treatments, but their standard of care has really moved down to more like 3 to 4 weeks. Because we give a little bit higher dose each day, and therefore, complete the treatment over a shorter timeline. So, yes. And then, for example, with the CyberKnife type treatment for prostate cancer, again, because we can give such localized radiation, we're able to give a higher dose each treatment and therefore shorten the number of treatments. So that's definitely kind of the direction that radiation oncology is headed and where a lot of the research is focused.
So in that case, it's gone from like 43 treatments down to 5 treatments. With a brain tumor, small metastasis in the brain, the radiation might be 1 treatment. And there are techniques in very early breast cancer, a very early stage, where you might do 1 treatment in conjunction with the surgery. So the breast surgeon removes the tumor, and we use a type of radiation delivery that in the operating room, you put the device in and give the radiation. Now there, you're only treating, though, that area. If a person has cancer where you think the whole breast is at risk, that's not going to be as effective, and you may be able to get the benefit of only 1 radiation treatment, but you have a higher risk that the cancer might be in other parts of the breast. So one of the things that we first have to do is decide what is the target, meaning what is the part of the anatomy we want to treat. If we decide that that is a small area, then we're likely to think about, can we do stereotactic techniques and do a high dose per day and very few treatments? If we think that the area at risk is the entire breast, all the lymph nodes under the arm and the lymph nodes above the collarbone, you can't treat that area in 1 to 5 treatments without horrendous side effects. And I mean, even, if you gave the whole body even a low dose of radiation in 1 treatment, that could be lethal. So the general principle, the bigger the area, the more we have to go a lower dose and more treatments. Maybe we want to add to that?
Perfectly said.
I'm sorry. We're at the end of the hour. We're going to have to bring you back. I really appreciate it. Dr. Emily Merfeld, radiation oncologist, MercyOne Cancer Center. Thank you for being our guest. If any of you watching this or anyone in the room knows someone that might benefit by watching this program over again, it's going to be available on demand tomorrow at the Above and Beyond Cancer YouTube channel and the MercyOne Cancer Center website. I hope you'll join us again next week for our cancer education series. Thanks for being here. Are we done? I'm still smiling. Usually it ends with, we're off.
Oh.
Are we still on? I can't tell if we're on or not.